Namaskar, dear viewers. Welcome to today's Young India Intensivist Critical Lines episode. And today we have a very special guest with us, Dr. Bhuvana Krishna. So, ma'am is professor and head Department of Critical Care Medicine at the very prestigious St. John's Medical College, Bangalore. And many of you had requested that ma'am has never appeared on any of our webinars. So she had very kindly consented to be here with us today. So I'm really glad about that. And ma'am is the associate editor of Indian Journal of Critical Care Medicine, and she's the author of several publications in terms of articles, in terms of book chapters, and I think she has even authored a book. So it'd be very nice to hear from us, and we shall start off now, ma'am. Ma'am, is it okay to start now?
Yes, Dr. Tapesh. Thank you. Thank you for the kind introduction.
Okay, ma'am. So the first question, ma'am, is what is ventilator-induced lung injury, VILI, and why is it important?
Yeah. So I think this concept of ventilator-induced lung injury is actually gaining a lot of importance. It's not that this is a new concept. It was studied several decades back itself on animal models. So in short, if I have to say, ventilator-induced lung injury is nothing but a worsening in the lung condition or a new onset of a lung injury caused by mechanical ventilation. So that is why it is called as ventilator-induced lung injury. We always think putting the patient on a mechanical ventilator is actually going to be beneficial. But it is also important for us to understand that if we don't keep the correct settings for the patient, the mechanical ventilator itself can cause a lung injury or a lung inflammation. So this is something that we need to keep in mind. And ventilator-induced lung injury is important because it can be associated with high morbidity, increased days on the ventilator, worsening oxygenation, and mortality also. So this is something that we need to keep in mind. So the concept ventilator-induced lung injury is becoming more and more aware among the intensivists, and we need to keep in mind when we treat our patients day to day in the ICU.
So, what are the mechanisms of ventilator-induced lung injury, ma'am?
So I'm sure if I'm going to ask these questions to any of the intensivists or the trainees or fellow trainees, so if you see, they would rattle out it is volutrauma, barotrauma, atelectotrauma, biotrauma, and the new concept now ergotrauma also. So if I have to put it in short, any of the settings that I keep on the ventilator, which exceeds certain, limits, it can cause ventilator-induced lung injury. So the first and foremost, the most important setting on the ventilator, which we need to keep in mind, is volutrauma. So we need to keep the tidal volume at a range of, in a normal lung, 6 to 8 ml per kg body weight. There has been enough and more studies which have said that when we cross this 8 ml per kg body weight, I'm talking about per kg body weight is the predicted or the ideal body weight. So based on that, if I cross 8 ml per kg body weight, there is enough and more evidence to say this can predispose the patient for ventilator-induced lung injury. Just the volume itself can cause ventilator-induced lung injury, which is called as volutrauma. And if I'm talking about ARDS, we need to target a much lower tidal volume, which is 4 to 6 ml per kg body weight. The next is the barotrauma. So the next, meaning to say, tidal volume or volume trauma is the most important, inciting cause for ventilator-induced lung injury. The second most is barotrauma. Here, what I'm looking at is I need to target plateau pressures lower than 30. Anything crossing more than 30, there has been evidence to say that plateau pressures crossing 30, there is incidence of barotrauma in the form of worsening ventilator-induced lung injury or pneumothorax or any other pneumomediastinum. So this is the complication due to barotrauma. Atelectotrauma, as the name itself implies, it is the constant, opening up of the alveoli and, collapse of the alveoli, because these alveoli, especially in patients with ARDS, there is a deficiency of surfactant. So the alveoli at the end of inspiration are unable to be, in a particular size for the inflation. So there is a shear stress between the alveoli leading to inflammation. So this also predisposes to atelectotrauma. And the other is your biotrauma. Just the inflammation due to the high tidal volume or the high, inflating pressures, or due to the constant opening and closing of the alveoli. This itself sets a cascade of inflammation leading to release of cytokines and biotrauma. The last, which has become more popular of late, is ergotrauma, which is due to the mechanical power, which is the energy that is needed to inflate the lungs. So this mechanical power includes both your compliance components, your resistive components, your PEEP, and the respiratory rate that you set. So all of these put together are important factors in the development of ventilator-induced lung injury. So all of these we need to keep in mind.
Thank you for the answer. So it's, I may just add to that, ma'am, that it's very important to realize that nobody gets cured by the ventilator itself. Ventilator is just an adjunct, and the main role of ventilation is not to cause further injury. Like it said, primum non nocere. First, do no harm. And I think that is very apt for mechanical ventilation, that we should not be causing harm with our process of mechanical ventilation.
So it's becoming more and more important for us to realize that we are using a tool, and we should not cause injury to the patient while using the tool. So that is why ventilator-induced lung injury is something that all of us need to be aware of. It's not that you put the patient on ventilator and we forget about it. We have to see whether it is safe also, that the settings that we have kept for the patient.
Right, ma'am. So next question is, what are the complications associated with VILI?
Yeah. So as I already mentioned in the last few minutes about the pathophysiology of VILI. So VILI can worsen an existing lung pathology, like if there is a pneumonia or there is an ARDS. So it can worsen because of the inflammation, and that sets in because of all our inappropriate settings. So it can lead to worsening oxygenation, and it can further lead to worsening ARDS, where you may need to go up on the PEEP, or you may need to prone the patient, or there could be other complications due to barotrauma in the form of a pneumothorax or a pneumomediastinum or a subcutaneous emphysema, or there could be development of pulmonary edema, or there could be, patients can develop diaphragm injury. This is not a part of VILI itself. All these components that I have told can also lead to a diaphragm injury and difficulty in breathing from the ventilator. And because of the worsening oxygenation, pulmonary edema, there could be prolonged, ventilator days, ICU days, and increase in ICU mortality also. So these are some of the, different problems that we can face due to VILI. The most important is worsening of the lung condition is something that we need to keep in mind. We may think that the underlying lung itself is progressing, but it may be that our ventilator settings itself is further causing problems to the existing lung.
Thank you for the answer, ma'am. Then moving on to the next question, there is VILI, and now we have also P-SILI, which has been coming into its own in the last few years, that is patient self-induced lung injury. So what is the difference between VILI and P-SILI?
So if you see, ventilator-induced lung injury is something that it is like we have put the patient on the ventilator and it is a controlled mode and you have kept the settings. But VILI can, if it happens in a patient who's spontaneously breathing, that is, if the patient himself is taking, higher tidal volumes, or he is causing great, changes in the intrathoracic pressures, his efforts are very vigorous. That itself can cause a lot of inflammation in the lung. So this is called as patient self-inflicted lung injury. That is just the patient's efforts, the size of the tidal volume, or the increased respiratory rate, or the negative inspiratory pressures, which causes a lot of different changes in the pressures, what we call as a transpulmonary pressures, can be different in different regions of the lung. This can lead to pendulum effect. That is, the transpulmonary pressures may be different from the dorsal to the ventral parts of the lung. So air can the air in the alveoli can move from one region to another region. This can lead to collapse of the already recruited alveoli and the overdistension of certain alveoli. This itself can lead to, again, polytrauma, barotrauma, atelectotrauma, biotrauma, and worsening in patient's lung condition or new onset lung condition. So this is in just patient self-inflicted lung injury. And patient self-inflicted lung injury can happen if the patient is spontaneously breathing itself, if the patient is on NIV, or if the patient is on mechanical ventilator but on a pressure support mode of ventilation. So in any of these three conditions, you can it can result in patient self-inflicted lung injury.
Thank you, ma'am. Then moving on to the next question. What are the parameters to be monitored for preventing VILI?
Yeah. So we know that VILI is very important. We know that we need to, prevent VILI. So it is something that we need to monitor also. We may think, okay, we've got guidelines which says 6 to 8 ml per kg body weight, or in ARTS 4 to 6 ml. Plateau pressures, we should target less than 30. We may be abiding to all of these, but still, we don't know what is the correct tidal volume that we need to set for that patient. We don't know what is the correct respiratory rate, what is the correct plateau pressures that we need to target for in order to reduce the ventilator-induced lung injury. So for that, we need to monitor certain things, certain settings on the ventilator to see that should I titrate my tidal volume to a lower tidal volume. So what are the things that we need to look at is, one is plateau pressure. Plateau pressure, as we've already mentioned, that we need to target less than 30. But plateau pressures alone may not be sufficient. We may need to look at driving pressures. Amato and his studies have shown that a driving pressure cutoff more than 15 is associated with higher mortality, especially in patients with ARDS. So why is driving pressure more important than plateau pressure? We don't know whether it is the poor compliance or the higher PEEP is causing the higher plateau pressure. So you're going to remove the component of the PEEP. So plateau pressures minus the PEEP will be giving me the driving pressure. So if the driving pressures are higher, what it means is my compliance is poor, and I'm keeping a higher tidal volume for the baby lung, or the lower compliance of the lung. So I need to target a driving pressure less than 15. So how do I target a driving pressure less than 15? Either I need to improve the compliance of the lung, which the disease itself may take time for improvement, and so that the compliance improves. or I may need to recruit the lungs by either proning. Recruitment maneuvers has not shown any great benefit. So I may need to prone the patient so that I can, improve the compliance. And for that compliance, I need to keep a lower tidal volume. So it is very important to target a driving pressure less than 15. And how do I do it? I may need to look at, as I said, improving the compliance or lowering the tidal volume, because driving pressures more than 15 is associated with higher mortality. Second thing that I need to target is I may need to calculate the mechanical power too. Mechanical power, as I said, we may need to look at not just the tidal volume, but what is the respiratory rate, and is the PEEP also contributing to the higher mechanical power? So a mechanical power in normal lungs, we need to target usually less than 12 joules per minute. And studies have shown that a mechanical power more than 17 joules per minute can lead to, the development of ventilator-induced lung injury. So I need to look at how to reduce my mechanical power. So a lot of studies are coming up to see how to reduce, and is it associated with a better outcome? Although the evidence has not been so great, but this is something that we need to keep in mind. We shouldn't be. That is why we shouldn't be going on increasing the respiratory rate, causing more injury to the the lungs. So we are looking at driving pressure is a static parameter. So the driving pressure into the respiratory rate will be my mechanical power. So I need to look at even the respiratory rate. So this is another component that I need to look at. Sometimes the driving pressure may not be sufficient, especially in patients with, who have intra-abdominal hypertension or pregnancy, or those with a very poor chest wall compliance. Then my driving pressure may not be reflective of the true compliance of the lungs, because the driving pressure will include both the compliance of the respiratory system as well as the chest wall compliance. In such instances, it would be useful to have a transpulmonary pressure. So the transpulmonary pressure and monitoring of the TPP, where we can target the delta transpulmonary pressure of less than 15. Those targets also would be helpful in reducing ventilator-induced lung injury. So these are some of the few things that we can look at. One is simplest is if I have to summarize, the simplest is to target a plateau pressure less than 30. We definitely need to look at driving pressure. It would be advisable to look at even mechanical power if you can calculate it. It's a complex formula, but we have online calculators where we can enter the values and it will give you the mechanical power. And if you have a situation where you need to, measure the transpulmonary pressure, as I mentioned, in certain special situations, and you have the tool, then it would be advisable to place an esophageal balloon and get the transpulmonary pressure and titrate the PEEP according to the transpulmonary pressure. So these are some of the things that we can monitor. In order to reduce ventilator-induced lung injury.
Thank you, ma'am. Now moving on to the next question and the final question. How do you prevent P-SILI?
Yeah. So as I mentioned, P-SILI is also something that we need to keep in mind, and especially when a patient, where we have put the patient on NIV, or if the patient is spontaneously breathing. So spontaneously breathing, it may be difficult to monitor. But when the patient is on NIV and he's got a very high respiratory rate, or if you can see the P.1, And P.1 is your, occlusion pressures at the, 100 milliseconds, where the ventilator itself checks the, P.1. And if it is more than 3.5, 3.5 means the patient is having a very high respiratory drive. If the respiratory drive is high, and second is if the patient is taking very large tidal volumes, more than what we said, the target of more than 8 ml per kg body weight, and if the patient is hypoxic and you are suspecting ARDS, it is more than 6 ml per kg body weight, these patients are definitely prone for P-SILI. So these are two things that we can look at. Is the patient having a very high respiratory rate? Is the patient having very large tidal volumes he is generating? Or if the P.1 is more than 3.5, this indicates that the patient's respiratory rate drive is high and he is at high risk of P-SILI or patient self-inflicted lung injury. Similarly, if the patient is on spontaneous mode on mechanical ventilation, also the same parameters we can look at. So how do you reduce the P-SILI? If the patient is on NIV or he's spontaneously breathing, it is advisable to intubate the patient. Otherwise, there is going to be worsening in the oxygenation. So you need to intubate. And if after intubation, or if the patient is on spontaneous mode on mechanical on the mechanical ventilator, it is advisable to sedate so that his respiratory drive comes down. But most important, you need to treat the etiology of why this patient is having a high respiratory drive. Is he having a metabolic acidosis? Is it a metabolic component, or is it a central component like a neurogenic cause for the hyperventilation? So we need to address the etiology of why the patient is got a high respiratory drive. If he's hypoxic and he's having a air hunger, so then you may need to increase flows or increase the FiO2, or we may even need to keep a higher PEEP in order to recruit the alveoli. So this itself can reduce the air hunger and the increased respiratory drive. We need to sedate, as I said, so that his tidal volume and your rate can be brought down. And in the extreme situations with these measures, still if the patient's respiratory rate is high or his tidal volume generation is very high, it may be necessary even to paralyze the patients temporarily, not for a long period, because we know that use of neuromuscular blocking agents itself has its own hazard. So whatever, even if we use the neuromuscular blocking agents, it's going to be only for a temporary period, just to tide over that time so that the patient's air hunger or the respiratory drive reduces. So these are some of the measures that we can use to reduce your patient's self-inflicted lung injury. So the most important here is we need to take control over the patient's respiration and see to it that we keep to our targets to reduce the lung injury.
So that was the last question. Also, if I may just add to that, we have high flow nasal cannula and we have NIV. So probably high flow nasal cannula also mitigates P-SILI to some extent better than NIV. That is why it's more useful when PF is less than 150. We don't advocate NIV for PF less than 150, but high flow nasal cannula may work because it addresses P-SILI much better than.
The most important here is if there is increased work of breathing, then your high flow nasal cannula also probably may not work. And if you put the patient on NIV and your work of breathing comes under control, okay. But if the patient has an increased work of breathing and he has a very high respiratory drive, then I don't think HFNC or NIV would work. It would mean that we need to, even though he may not be hypoxic, his CO2 may be okay. But in those instances, we need to take control over the respiration in order to reduce patient self-inflicted lung injury.
So thank you very much, Dr. Bhuvana Krishna ma'am. That was lovely listening to you, and I think it was very nice for the audience also. Soon we shall put up the recording on our YouTube channel. I thank thank the viewers and I thank ma'am for her wonderful contribution. Thank you, everybody. Good night.
Thank you, Dr. Tapesh, for the opportunity. Thank you.